starting with depression, what is depression? Can anybody tell me? I think we've probably all thrown around that word, like, oh, I'm feeling depressed today, or that patient looks depressed. But what does that actually mean? What does it mean to be depressed?
The feeling of sadness.
Mm-hmm. Feelings of sadness. Withdrawal, yep. Yeah, so I think there's a lot of ways to understand depression. So I think sadness often comes up, but I think depression encompasses more than just sadness. Right? Sadness is a very specific emotion. Depression tends to be very pervasive. Right? So what do I mean by pervasive? It tends to affect people in multiple domains of their life. So one thing I like to educate patients on is, if a family member passes away and they're having a reaction to it, they're most likely feeling sad, as a result. The moment it turns into depression or some sort of more complicated disorder is when they cannot be consoled, they become withdrawn, they cannot be, they don't reach out to family members, right? When we go through a normal grieving process, we are comforted by our loved ones and the people around us. Oftentimes in depression, people are not so easily comforted, and so they do become more socially withdrawn, right? So while sadness is a very specific emotion, depression tends to be a very vague and pervasive type of disorder. And it's often underdiagnosed in older adults. And this is partly due to stigma associated with it. I think some of the older generations are not as forthcoming with their feelings. And then two, it looks a little bit different in the older population compared to how you or I might identify when we're depressed. So the symptoms they present with are a little bit more atypical, and so it's harder for providers to catch on to that, and also harder for patients to say that, oh, I'm feeling depressed, I'm feeling more withdrawn. Okay. So when evaluating for depression, there's a lot of different sources of low mood. So of course we have depression, which is major depressive disorder, dysthymia or persistent depressive disorder. There's also grief, right? Grief is a very common theme in this patient population. And of course, there's sadness. My family didn't visit me this week, or I got into an argument with my friend, etc. And medical reasons. So this is often overlooked, and we don't. Historically, we haven't done a very good job in exploring the medical reasons. So a lot of medical diagnoses can lead to depressive type symptoms. And so that's really important for us to evaluate for and treat. And so things that I think about when I see a depressed patient is, how long has this been going on for? So, has it been going on for weeks, 2 months? Has this happened before in their life? When was the last time they felt overall well? And how many days out of the week is this affecting them? Is it almost every single day that they're feeling withdrawn and feeling like all their joy has been sucked out of their life? Or is it just 1 or 2 days where they might feel down, right? So these different criteria help me figure out just how severe the depression is. And finally, can they be cheered up? So traditionally we think that people who are experiencing grief or sadness, they can be cheered up. They respond well to social influence. People come in to support them. They feel better. People with more complicated grief processes or depression may not necessarily respond in that way. Okay? So, like I mentioned earlier, the symptoms that older adults experience when it comes to depression can be very different from how you or I might identify depression. So if you or I walked into a psychiatrist's or a therapist's office and for depression, we probably came because we felt like we had low mood, we felt like we were becoming more socially withdrawn. It was more difficult for us to interact with our peers, etc. In older adults, this tends to be not as common. So older adults don't experience the same levels of guilt or low self-esteem as younger adults do. And so some of the symptoms that we see more often in older adults include anhedonia, which is a fancy word for lack of joy in one's life. So, an older adult might used to love fishing and golfing and, various activities. But over the last few months, you've noticed that they've become less involved in those activities. The same activities do not bring the same level of joy, essentially, as anhedonia. Somatic complaints, meaning physical symptoms. So older adults are very prone to physical symptoms, even in depression. So one of the most common complaints I get from older adults who are depressed is, I just haven't been feeling very well. My stomach's been really hurting. I just have so many headaches. I don't want to do anything. And so, it's easy to write it off as, oh, well, this person just has, headaches and stomach aches, and that's why they're not doing anything. But there is a high likelihood that there's a component of depression there. And then anorexia or food refusal, so diminished appetite. I think this can be a little bit insidious as well. Sometimes we think of older adults as, well, with age, they eat less. That might not always be the case. And if there's been a noticed weight change, that's something to take note of and pick up on. Psychomotor disturbance. So what this means is this person moving more sluggishly than usual? Do they just appear more slow? They kind of drag their feet as they, move around. Behavioral regression. So this kind of goes back to what Dr. Barsegian was talking about. Sometimes depression can look like dementia. So sometimes older adults, they seemingly lost some of their functional skills day to day. They're not cooking as much. They're not going out to get groceries. And you're wondering, well, are they becoming demented, or is it just they don't want to engage in these different behaviors that support them in everyday life? And then poor concentration, which is which leads to poor memory, poor attention, which can then be misdiagnosed for dementia. And insomnia is a huge one. As we get older, many older adults start to require less and less sleep. And so when you compound this with depression, they may not be sleeping much at all. We're talking like 2 to 3 hours a night. They might be waking up very early in the middle of the night. They might be laying in bed for long periods of time before they're able to fall asleep, that kind of thing. And of course, with decreased sleep and decreased sleep quality, we exacerbate depression, and they're at higher risk of developing dementia and other cognitive issues. So what are the risk factors for developing depression? So when we think of geriatric depression, there's really two camps. The first camp are those who develop depression later in life, like they've never been depressed in their life, and this is the first time they're feeling depressed. The other camp is people who were depressed in their 20s, 30s, 40s, and now in late age, they're developing depression again, right? So each of these types, or both of these camps, they each have their own risk factors. So in the first camp, where people are developing depression for the first time in later life, it's often due to a mix of, shrinking brains, could be due to various strokes or mini strokes in their brains that have gone undetected. So basically long-term brain damage as a result of, living a long life, right? But then also significant loss. So bereavement, grief, that kind of thing, that contributes to developing depression later in life. The people who have had depression all their life, in their early adulthood into older adulthood, This is often due to family history, genetics, childhood trauma, socioeconomic factors, and some contribution of perhaps personality and ability to utilize coping skills and whatnot. So what are some things that protect against depression? So we know that good cognitive and good physical health are protective factors. They help guard against depression. So if someone is physically active, they're out and about, they're mentally engaged, this population tends to be less depressed. The people who are, they keep to their rooms, they're not physically active, their physical health is poor, and they're not mentally stimulated, this population is more prone to developing depression. And it almost seems obvious, better socioeconomic and more financial resources tend to protect against depression. Right? It's basically, if we had more money, we wouldn't be depressed as much. And importantly, sense of community, right? And religion is a big part of this. Going to church can be a very meaningful activity for a lot of older adults, having a sense of purpose. And I think what pays us really well is having that sense of community, right? So, a place where people can go and have peers, meet with various team members. And the ability to self-reflect, is our patient or participant, able to self-reflect on their life and their goals, what's meaningful to them? The people who are able to really do this and verbalize this kind of thing, they tend to be more protected against depression. It's the people who are very rigid in their thinking who tend to develop depression. Okay? So when is depression dangerous? Basically, when they are hurting themselves or there's a concern for suicide, right? So Dr. Barsegian kind of alluded to this earlier. There's various types of suicidal ideation. The most basic form is passive suicidal ideation. So, we hear this commonly, if I don't wake up the next morning, I'd be okay with that. If something happens to me, I'm not too concerned. That's in the realm of passive. Now, when it's active suicidal ideation, it's more along the lines of, oh, I wish I wasn't alive anymore. Oh, my life really sucks. I wish I could just pass. I want my suffering to end. I want my life to be over. And with active suicidal ideation, there are several components also. Does this person have a plan? I want to shoot myself, or I want to hang myself, or I want to overdose, right? These are very specific plans. And how detailed is that plan? I want to take an overdose, but with what meds, right? Are they going to go out and get a bottle of Tylenol, et cetera? The more detailed the plan, the higher the risk, because it's the person has given it more serious thought. Right? And do they have any intention of doing it? Some people might have a plan, like the thought has crossed their mind, but they don't have any intent on carrying it out. So, I always like to ask, well, if I gave you a bottle right now, like, would you do something with it? I think that can be a very confrontational or scary question to ask. But in my experience, patients have responded to that type of questioning. I don't think patients typically shy away from answering those questions. And I think it shows them that you're listening and you're concerned and you want to know the ins and outs of what they're going through. And we'll talk more about the risk and protective factors when it comes to suicide. And one component of depression that I think is sometimes overlooked is food and drink refusal. If they have been refusing food and drink for days, that becomes a medical emergency and they need to be treated, both for the depression and for any medical issues that may arise from the food and drink refusal. Right? So naturally, all of this requires an immediate evaluation by the provider, either the PCP or the psychiatrist, and possible 5150 for hospital level of care. Okay? So risk factors for suicide. So this data comes from the CDC, I believe. And to summarize, basically older single white men are at highest risk. And then included in there are also Native Americans, any substance use, any history of psychiatric illness, past suicide attempt is a huge, huge risk factor for a future suicide attempt. Any access to lethal means. The geriatric population tends to attempt fewer times, but their attempts tend to be more deadly, right? So the percentage of deaths by suicide is actually highest in the geriatric population. So you compare that with the adolescent population, which has many, many attempts, but few are lethal, right? So not that we have to be less concerned for one or the other population, but if someone in the older population is telling me they're feeling suicidal, I'm really concerned, right? Because the risk of death by suicide is fairly high. And we've discussed some of these other topics like physical illness and reduced functioning, people feeling like their life isn't worth living anymore. It's more difficult to do the things they love. Alcohol use, but certainly any substance use. And long-term care and prospect of impending placement. I think one of the goals that we all have in common is we want our patients or participants to grow older in the community, at home where they're most comfortable. And for a lot of people, it's very scary to think about nursing home placement or other types of long-term care facilities. Because what does that entail? It entails losing a lot of independence. It entails maybe diminished contact with family or friends, not as much activities for them. So this is something that a lot of people see as a negative, right? And it is one of the risk factors for suicide in this population. So how do we reduce suicide risk? The first and foremost is early detection. If we don't ask for it, we won't find it. Some patients might tell you they are suicidal or that they are feeling really depressed, but it's the really silent ones that always scare me, right? Because they're serious about it. They're not going to tell anyone. They want to die, right? So they're going to go out and do it. So making sure that we ask often. And statistically, most deaths by suicide actually happen before the patient even reaches their primary care office, much less a psychiatrist, right? So by the time they're with a psychiatrist, chances are much slimmer, but it's the access to care to begin with. Is the patient going to see their primary care doctor? Is the patient even connected with a primary care doctor? And in older adults, well, let me preface by saying, in the general adult population, like you and I, when we're feeling depressed, we often have a whole list of issues that make it very clearly depression, right? And so we go to the doctor or we go to the therapist and we are able to list out what's going on in our lives. In older adults, there's this phenomenon called subsyndromal depression, which basically means depression that doesn't quite hit all of the criteria that we're used to looking for. And so in that way, it gets missed, right? So like my example of an older patient who just has stomach aches and headaches, and for that reason, they're not leaving their room too much. That person doesn't hit much criteria for depression, And if we go by the traditional checklist, they might not meet criteria at all. But these are the patients that we need to be more aware of, and those are the patients that we classify as subsyndromal. They don't quite meet criteria, but there's something going on there that makes us concerned. And of course, we want to treat other psychiatric disorders. We know that multiple psychiatric disorders make the risk of suicide very complicated. And we know that insomnia and severe untreated anxiety are independent risk factors, meaning they increase the risk of suicide even without depression, right? So when you overlay that with depression, things get really messy really fast. And then, of course, we always want to involve family and community supports and establishing some sort of safety plan. So do you guys know what I mean by safety plan? Yeah. So basically, coming up with an outline of who do I call when I'm in distress, what are signs that I might be in distress, and what should I do? Should I call 911? Should you call someone for me? That kind of thing. And so that way, the patient and you are all on the same page on what to do when they're feeling in distress. So comorbidities in depression include anxiety, substance use, often to self-treat, worse medical outcomes. So we know that people who are depressed, compared to those who are not depressed, if they're both going through the same physical issues, the person who is depressed tends to have worse outcomes. And this, of course, leads to poorer physical functioning. And with poorer physical functioning, you can imagine worsened depression. So it's a very vicious cycle. And all of this leads to shorter life expectancy, more withdrawal, sleep issues. So the treatment for depression most commonly would involve a SRI. So SRI is short for serotonin reuptake inhibitor. And you've probably seen ads throughout the years on television. Zoloft, Prozac, Cymbalta, Lexapro, Celexa. All these are considered serotonin reuptake inhibitors. And these are fairly safe medications, right? They tend not to be sedating. Their most common side effect is stomach upset, but only for the first few days, usually. If they've been taking a medication for a long period of time and they develop stomach aches, it's probably not the medication. There's probably something else going on. And mild or moderate depression can and is often treated by the primary care doctor. Severely depressed or suicidal patients will often need a psychiatrist and often a therapist on board. And of course, I almost never treat a patient for depression with just medications. I'm a very big proponent of therapy. I think it plays a very crucial role in the patient's well-being. So I always recommend those two hand in hand. And moving into, before we move into anxiety, any questions about depression? Okay, very good. So moving into anxiety. So anxiety, I think of it as excessive worrying or fears. So, for me, feeling anxious usually happens in the context of deadlines, right? Deadlines coming up. I'm feeling, oh my gosh, I need to finish this. And you and I, we might have similar anxieties, But for a lot of our patients, anxiety can be a very time-consuming illness. They're constantly worried about everything, right? They're worried about, I need to pay my finances, even though that's not, an immediate issue. I'm worried about my daughter's health, even though she's in pretty good health. I'm worried about this, I'm worried about that, I'm worried about this, I'm worried about that. And so the list can be endless about things that they worry about. So when it gets to that extent, we call that generalized anxiety, right? They're just generally an anxious person. They're worried about many things. It could be anything and everything. And like I mentioned earlier, anxiety often goes hand in hand with depression. I think of it as two sides of the same coin, right? So people who are depressed, they tend to live in the past. They reflect on all the things they did wrong, all the guilt they've been through, etc. People who are anxious, they live in the future, right? And they are worried about what might happen, right? And so you gotta help them live in the present, right? Signs and symptoms include pacing or restlessness. Someone's just walking up and down their homes, unable to sit still, constantly stressed. They can be very irritable, and difficulties falling asleep is a common issue. Okay? So imagine laying in bed, reflecting on all the things that you need to do tomorrow, right? So that a typical picture of depression, anxiety. So how do we evaluate for anxiety? I always like to get a good sense of, well, what are they worried about? Are they worried about just one thing, or are they worried about many things? And the things that they are worried about, are they reasonable, right? Does the worry make sense? And the reason why I figure all of this out is because it helps me figure out what specific diagnosis this might be. So anxiety actually is a pretty broad term, and there's multiple disorders that fall under the umbrella of anxiety. So one disorder I mentioned earlier is generalized anxiety disorder, right? That's your bread and butter. I'm always worried, I'm always stressed, I'm always anxious, just about everything. And then there are specific phobias, right? So I'm scared of spiders, I'm scared of heights, I'm scared of various things. Panic attacks, which typically is described as walls closing in on the person, a massive amount of anxiety hitting them all at once. I usually liken it to being hit by a brick wall of anxiety. And this could happen due to specific triggers, could happen without specific triggers. And obsessive compulsive disorder. So obsessive compulsive disorder, we have obsessions. I must check the door 17 times before I leave, or else someone will break in, right? So I will spend a lot of time checking the doors over and over again. Or I must stack my soda cans in a particular way in the refrigerator, or else something bad will happen, right? We differentiate that from people who are just a little, I guess, anal, people who are just neat in terms of their personality. They like to have things organized, right? And to what degree is the anxiety interfering with the person's life? Are they basically disabled because of it? They can't leave their home because of their anxieties. Are their social and personal relationships affected? Is their occupation affected by it? They can't go to work because of their anxiety, right? So these are all things that we like to know. So comorbidities and anxiety, of course, depression, and substance use disorders, which will be a recurring theme. A lot of people will use substances as a way to cope or to self-medicate. And like I mentioned earlier, people with anxiety, it's hard to fall asleep, worse health outcomes. And high stress levels, is correlated with shorter life expectancies. So it's important that we look for anxiety. And it's the second most prevalent mental illness after depression. Okay. So when is anxiety dangerous? Untreated anxiety can be a risk factor for suicide. But I would say in the grand scheme of things, anxiety is probably not on the same tier as depression or even psychosis in terms of danger, right? Oftentimes people who are very worried, their lives may be very uncomfortable, but they are not at any imminent risk of hurting themselves or hurting someone else. So in that way, we can kind of take a breather and we can try and treat outpatient. But certainly there are cases where we will admit to the hospital because the patient just cannot function without additional support. Okay. So treatment for anxiety, usually a serotonin reuptake inhibitor, similar to depression. You might find that patients can be, or may be on a variety of other medications, sometimes PRN medications. In the older population, we try to avoid benzodiazepines as much as possible, and those are sometimes used as PRNs, and we hate it. So some examples of benzodiazepines are anything that ends with PAM or LAM, right? So alprazolam, lorazepam, diazepam, right? So anything that ends with that suffix is probably a benzodiazepine, and older adults shouldn't really be on that medication long term. Okay? It's very helpful for anxiety, but it's also a very sedating medication. So treatment of anxiety, if it's a low-grade anxiety, it can probably be managed by the primary care doctor, and therapy. I think therapy is very helpful in that it provides the patient some coping skills and some distraction-type skills. Severe anxiety, OCD, panic disorders probably need some form of medication management, should likely see a psychiatrist for it. Any questions on anxiety so far? Or anything at all? Okay, good. Okay, now we move into substance use. So when we say substance use, we are talking specifically about psychoactive substances, right? Substances that alter the way we think and see the world, even temporarily. So this first bullet point I included recreational substances. So this includes alcohol, cannabis, also known as weed or marijuana, and caffeine. Alcohol and caffeine, I think those two, we're probably all familiar with those substances. When asking about these substances, I try to get a good sense of how dependent are they on the substance. Can they go a day, a week, a month without it? Can they cut back when you ask them to? How frequently are they using it? Under what circumstance are they using it? What is their relationship with the substance? I only drink when I get into arguments, right? That's probably not a good reason to drink, right? With cannabis, I always ask about, are you using CBD or are you using THC, and in what forms? Are you using like CBD oils, or are you having edibles? And same thing with the THC, right? And finding out what percentage it is. The higher the THC component, the higher the likelihood of developing other psychiatric issues like depression, anxiety, etc. CBD, I'm usually okay with. CBD, the studies have shown to be pretty helpful, but it's the THC, the getting high part that is not so good. And that's been shown over and over in the research that it's no good. The next bullet point, I included some of the common, I guess we could call it like illicit street drugs, opioids, cocaine, methamphetamine. So these have various ways of taking them. Many of them you can take intranasally, like through your nose. You can also use IVs for it. Some of them you can ingest by mouth. So these, it takes a lot of effort to get a good history on these substances in particular. And and how long they've been using it for, and what type of impact this substance has had on their life. Okay. But I find that these three, the opioids, cocaine, methamphetamine, these are some of the most disastrous drugs. Of course, alcohol is high up there too in terms of bad outcomes, but I usually get more concerned about the other three. And then the last bullet point, LSD, ketamine, psilocybin. So these are hallucinogen type products. So like think of shrooms, things that make you see, fractals and colorful visions and that kind of stuff. These tend to not have as much of an addictive component to it, but with unsupervised use, there's still a higher chance of developing psychosis long term. So we still do not recommend, a patient just using these substances. So the reason why substance use is so important to ask about is, most substances have some sort of mind-altering effect, and this leads to poor insight, poor judgment, reckless behaviors, that kind of thing. So an example of reckless behavior would be, someone very high on meth or cocaine and, barging into buildings or breaking into premises, doing things that they normally wouldn't be doing. So one thing that I always like to understand is why do people use? So whenever I'm sitting with a patient who has some sort of substance use disorder, I like to ask, tell me, like, what does this drug do for you, right? Or what does alcohol do for you? What does it provide in your life? And that poses a pretty neutral question. And I think it's less stigmatizing than, going on and on about all of the bad outcomes that might arise from drug use. All of our patients have heard the same spiel over and over. So I find that the best approach is to approach it neutrally. Patients are more likely to just tell you, I've just been going through a difficult time. This helps me feel a little bit better. And then that gives you something to work with, right? And a lot of drugs feel really good, right? Especially the uppers. So by uppers, I mean like cocaine and meth, these stimulant type drugs. They make you feel really good in your skin temporarily, and then you have that crash afterwards, and it's the worst feeling in the world. But acute intoxication also feels good. Cannabis, acute intoxication, people get high recreationally. People get drunk recreationally. And sometimes people use it just as because they have poor coping skills, right? They don't know how else to deal with their frustrations or their anxieties or their depression. And so they use particular substances. And genetics or habit is a big component. We know for sure that children of alcoholics are at a higher risk of also developing alcoholism. And these studies are interesting because, even if we take the child from the alcoholic parents and the child is raised in a non-alcoholic family, that child is still at higher risk of developing alcohol use disorder. So these are things to inquire about. I know that sometimes we can think of substances as, oh, well, you're choosing to use it. For some people, it's quite literally, they cannot stay away from the substance because they tried it, they got hooked on it, and now if they stop, they will suffer a lot of rebound or withdrawal type symptoms, right? So, my emphasis here is to be less stigmatizing, go in with more of a neutral approach, because people use for all sorts of reasons, and it's really, really hard to stop. And people are going to struggle with stopping. So I acknowledge that right off the bat. I let people know that, when you're trying to cut back, it's normal to struggle. It's normal to fail. Most people cannot, succeed on their first try when cutting back on substances. And I think that normalizes the experience for them a little bit more. So comorbidities of substance use disorders. Substance use obviously affects our mental state and therefore can give rise to a lot of psychiatric illnesses. Any substance can lead to worsened mood. Any substance can lead to worsened anxiety. And most substances can lead to prolonged psychosis. So you might have people who were never psychotic before in their lives. They try drugs and this just like switches on a light of some sort, and then they just remain psychotic. So it's really important that we educate our patients. We also find that the longer the exposure to the drugs, the higher the risk of developing these issues, and the harder it is to treat. So, part of this, this all goes into the education for the patients. Let's see. And then, of course, using drugs are not without their physical consequences as well. Alcohol leads to liver damage, liver failure. Cocaine leads to brain bleeds, heart failures. Methamphetamine, especially IV drug use, leads to a lot of infections that are really, really hard to get rid of. So, aside from the psychiatric issues, there's so many medical issues that come along with substance use. So when is alcohol use, or when is substance use a problem? In previous iterations of substance use diagnosing, we used to think that amount correlated with, whether this is a problem. Nowadays, we understand it more of, to what extent is the substance, causing problems. You can imagine that someone who has, a glass of wine 3 to 4 times a night, that may still be problematic, right? Someone who binge drinks 7 drinks on a Saturday, but then they're like not doing anything else for the rest of the week or next 2 weeks. It sounds bad, but does it constitute a problem? Maybe not, right? So, understanding the person on an individual basis and seeing how their lives are affected by the substance is important. And one thing to keep in mind too is our patients, as they get older, they don't recognize that the amount of substance their body can tolerate actually decreases. So what I see often is someone who throughout their 40s and 50s had been having a glass of wine with dinner every night, and then they move into their 70s and they're still having a glass of wine every single night. The amount of alcohol at that point is not the same, right? It's a glass of wine each night in your 70s is going to be vastly different from a glass each night in your 40s or 50s. So reevaluating that, even if they say, well, I've always done it this way, this is the opportunity for you to kind of get in there and wonder, are you addicted then if you cannot even imagine cutting back, right? So there's a short little questionnaire that I use. It's a CAGE mnemonic. So the C stands for cutting back. Has this concept crossed their minds? Have they even thought of cutting back? A stands for annoyed. So are they annoyed by other people pointing it out, right? So when I get like a husband and wife duo and the wife always tells the husband, you're having too much beer, and the husband gets annoyed, that's a positive point on this questionnaire. Guilt associated with using. So, I feel awful for drinking so much, but I just can't help it, right? That type of sentiment. And eye opener. Do they crave it at random times of the day? Do they crave it when it's most inopportune, right? The first thing you and I, when we wake up in the mornings, we think about getting to work, most likely. For some people, they wake up and they think, oh gosh, I really need a drink, right? Because now their body has gone 8 or 10 hours possibly without a drink since last night. They're having some mild withdrawal symptoms. So the first thing on their mind is, oh, I've got to get a drink in me. That will make me feel better. So that's what I mean by eye opener, right? So keeping these 4 questions in the back of your pocket, it's helpful. And you can kind of apply this to all substances. I will say though, with the exception of alcohol, substances alone rarely pose an emergency. Alcohol and opioids. So with opioid overdose, obviously, this is all over the news, respiratory depression, right? With alcohol use disorders, I get worried about withdrawals. Alcohol is the only substance where the withdrawals are potentially lethal or fatal. All of the other substances, they can use and use and use, but their withdrawals will never be lethal. The withdrawals will feel really bad. It will feel very awful, but they will never die from it, right? But if someone is a chronic binge drinker, someone who drinks multiple drinks a day, and then they go on, they suddenly quit cold turkey, I get really concerned because that is potentially life-threatening. So some signs and symptoms of alcohol withdrawal includes sweating. They feel like their chest is pounding really, or the chest is really tight and their heart is pounding really fast or really strongly. They might feel more tremulous, so they get the shakes. They might get more confused, meaning they lose track of where they are. They start slurring their words. Later stages, they might develop seizures and ultimately potentially death. So really, really important to figure out. So anybody with an acute mental status change, they get sleepier or they get much more excited or agitated, over a day or two. That's something to notify providers about. So what is the treatment for substance use disorders? First and foremost, it's motivational interviewing. So this is a type of, I guess it's a type of therapy, but it's a type of way of, it's a type of interaction with the patient where you approach things very neutrally and you kind of put the ball in their court, right? What do you want out of your life? And how does this substance in particular play into that? I hear that you want to spend more time with your grandchildren. How does alcohol affect that? And how does alcohol play into that? This kind of thing. So you kind of lead them to the answer that they are looking for. And this leads to more sustained change because they get a sense of agency. They feel like they made the change. They feel like they've made the improvement. And they're more emotionally invested in that. Now, of course, there could be people who, cognitively and emotionally, I want to quit, I want to cut back, but they're finding that their cravings are just unbearable, right? Or their withdrawal symptoms are so unbearable. There are a lot of medications that can help with both cravings and withdrawal symptoms. It is important to note, though, that some medications used to treat substance use have street value. So, what patient can be selling their drugs or trading it for other resources. So something to keep track of. If we're prescribing, for example, Suboxone, and their prescription is running out early over and over and over again, we get really suspicious. It's not just coincidence that you're losing multiple doses a month, right? You're probably giving it away or trading it or selling it or something. And like I said earlier, patients will relapse. That's a fact. It's not meant to judge. And again, what is your relationship to alcohol? What is your relationship to marijuana? And what does it do for you? What are your reasons for using this particular substance? And I always try and remind myself that my role is not to convince them one way or another. My goal is to help them align with their goals in life. So for someone who goes on the occasional bender on the weekends, and they're highly resistant to changing, I'm not going to die on that hill, right? That might be a conversation we have down the line, and it might be something that we're very uncomfortable with. But if the patient's not ready to change, there's no point in forcing that door open. Psychosis, I know Dr. Barsegian talked about it briefly earlier, but just a broad definition of psychosis is a break from reality, right? So there's psychosis, think of it as an umbrella term, and there are a lot of symptoms that fall under psychosis. So the two that are most common are delusions and hallucinations, okay? So delusions, this is defined as beliefs that you cannot challenge, right? So when I'm speaking with a patient, I always make sure to assess whether it is a delusion or if it's just a thought, right? So someone who tells me, well, I think someone's following me because I looked out my window and I saw someone run by, right? And then I can challenge them to say, well, has it been happening every night? And how do you know? And they might say, well, I'm not sure, I'm not certain. So that's more of what we call paranoid ideation, right? But if I ask them the same questions and they say, well, I know for sure, I don't have evidence of it, but that's because they tampered with my, security, and, I know because I hear these noises every single day, et cetera, and they cannot be, moved on this topic. That then becomes more of a delusion, right? So I try to tease out, is this something that they're thinking about, but they don't have full buy-in, or is it something that they have fully bought into and they cannot be persuaded otherwise? Okay, hallucinations. So there's a lot of different types of hallucinations. Hallucinations just means perceiving something that other people cannot perceive. So most commonly, we talk about auditory hallucinations. So seeing things that other people can't. I think people usually understand this as hearing voices, but patients will sometimes describe hearing noises like metal clanging or footsteps that are not really happening. Patient lives alone and they're hearing footsteps on their one-story building, right? It doesn't make any sense. Or they might be hearing musical notes, right? So they could be hearing a variety of things, and these all fall under auditory hallucinations. The next most common type is visual hallucinations. So seeing things that other people can't, and typically this is in the form of little animals, little bugs, insects, could be little people in the room, could be shadows as well. 95% of hallucinations are auditory, so mostly hearing things. About 5% is the visual hallucinations, and then so there are hallucinations of sensation, like skin and taste as well, and even smell, but those are extremely, extremely rare. I wouldn't even think about that. Same thing with delusions. There's multiple types of delusions. We commonly talk about paranoid delusions because that's usually what the patient shows up for, right? So the patient shows up to us because they've been calling 911 nonstop because they feel like someone's out to attack them, or they've been calling FBI nonstop, right? That kind of stuff. But people can have delusions of, I think someone mentioned earlier, love, someone else is in love with me. People can have delusions, we call them bizarre delusions, like delusions that make no sense, like aliens are coming to visit us, or, oh, someone's removed my internal organs, things that are just not possible. So many types of delusions, and not all delusions are, makes the patient meet hospital criteria, right? People can live in the community with delusions. And again, I ask myself when I'm seeing patients, how is the delusion affecting their daily life? If someone believes that there are aliens out there, but they go about their day just fine, they're happy otherwise, I'm not going to push medications if they don't want it. If it's distressing to them, the concept of aliens coming to abduct all of us is distressing to them, then I would treat them because now it's causing issues in their life, right? And of course, if the delusions or hallucinations are leading them to do something dangerous, then that's time to treat. And we'll talk more about that later. Usually hallucinations are bothersome and scary, but I've had patients who are happy with their hallucinations. Some of them are okay with it being treated, and some of them will ask me not to treat it, actually. So some patients I've had, they've had like musical notes or like opera playing in their ears. And they're like, well, it doesn't really bother me. And it comes on and it's very relaxing to me. And I'm like, okay, that's totally fine. But that tends to be rarer. I think most of the hallucinations tend to be very distressing and confusing, right? And what are some signs and symptoms that this is going on? So people might be grasping at things that aren't there. They might be chasing after a dog or a cat that they saw. They might always be alarmed because they saw like a quick shadow flash by their eyes. They might be talking to themselves in the room. So we call that self-dialoguing, right? Talking to oneself. Or they're just doing really bizarre things. I had a patient once who went to his car, sat in his car and turned on the engine and sat in there for 4 hours just because a voice told him to. And no one thought anything of it until they went to find the patient, and he's just sitting there in his car. So these types of bizarre behaviors, they're usually brought on by some sort of hallucination, or sometimes delusions as well. Okay. So psychosis, is a pretty broad term. There's a lot of different disorders that can lead to psychosis. So most obvious is schizophrenia, and the whole spectrum of schizophrenia type disorders. So schizophrenia, schizoaffective disorder, and bipolar disorder can present with psychosis when it's really severe. And actually, severe depression will also sometimes present with psychosis. So when someone is telling me about their hallucinations or their delusions, on one part of my brain is thinking, oh, this stuff, is it dangerous or is it not dangerous? But the other part of my brain is trying to understand the content of what they're telling me. So if they're telling me something that is really morbid and really, really scary, like Satan is telling me to kill myself to save my children, that type of theme is probably related more to depression, right? So we call this mood congruent psychoses. We try and figure out, is there an element of the psychosis that could be driven by something else? So someone who is really depressed is overburdened with guilt. Their delusions and their hallucinations tend to follow that theme. Okay? Someone who's very manic and very excited and feels like they're on top of the world, their delusions are more along the lines of, well, I'm the savior, I'm here to preach to the world, and I'm going to walk out into the corner of the street and tell everyone. So the content of the delusions and the hallucinations is really important to pick up on. And like I mentioned earlier, substance use very, very intertwined with psychosis. Cocaine, meth, cannabis, these are huge, huge culprits for psychosis. Methamphetamine and cocaine, their forms of psychosis tend to be during the acute intoxication. So, right after using, they get super high and super manic-like. And then once the drug is out of their system, they crash and they kind of get back to normal. With cannabis, what we're seeing more and more is they're using, and then even after the drug has left their system, some of the psychotic symptoms persist. And we're finding that these psychotic symptoms that are secondary to drugs become a little bit more difficult to treat compared to just your bread and butter schizophrenia and bipolar disorder. And then when someone has schizophrenia and they use substances on top of that, that creates a lot of problems in terms of treatment, becomes much more treatment resistant. And then medical issues can actually lead to psychosis as well. So in older adults, nice old lady who's never had psychosis before, suddenly seeing spiders in her room. Most likely she has something going on medically. Urinary tract infection is a big culprit, okay? Especially with older females. An acute stroke, heart attack, liver issues, kidney issues, all of these issues can lead to psychosis. I will also mention that if someone is seeing things in their room and they've never seen it before, it's almost guaranteed to be a medical issue, okay? Schizophrenia, schizoaffective disorder, these types of patients, a very slim minority of them actually see things. The overwhelming majority of them hear things. So that's why my little radar goes off when I hear that a patient is seeing things, because to me it tells me that medically something might be going on. Okay? In terms of comorbidities, people with schizophrenia or bipolar disorder have a very high comorbidity with substance use. Bipolar disorder, in particular, has a very high coincidence with alcohol use. And then schizophrenia has a very high coincidence with tobacco, cigarettes, and other illicit street drugs. Psychosis can be comorbid with other mental illnesses. So someone who has psychosis can also have anxiety. Someone with psychosis can also have depression. So it's not, it's important to not overlook that. The treatment for psychosis is antipsychotics. So you've probably seen, many of these names before. So things like Haldol or haloperidol, Zyprexa or olanzapine, Abilify or aripiprazole. These are some common antipsychotics. And these lead to high blood pressures, obesity, high cholesterol. So, these patients with psychosis who are actively being treated, then, they have all these medical issues that we need to be concerned about. And there's also higher risk of stroke and heart disease. And because people with schizophrenia have a higher chance of smoking, their overall mortality is much higher than the general populations. Okay? So when is psychosis a problem? So very similar to when depression becomes a problem, right? So when they're a danger to either themselves, someone else, or they're doing something so reckless or so bizarre that it puts their safety at risk. So commonly, they might be hearing voices telling them to hurt someone, voices telling them to hurt themselves, voices telling them to not eat, delusions that the food is poisoned, so therefore, they cannot eat any of this food, things like that. So the moment their physical well-being or someone else's physical well-being is at risk, that is when a provider needs to be notified, they may require hospitalization. There was a question earlier about someone who was very paranoid and would have frequent hospitalizations, would get stabilized, would come back to the community, and then the process would restart all over. I would say at that point, that person may not be suitable for PACE anymore, and there are other models of care that might be more suitable. So assertive community teams can also be, or assertive care teams can be very helpful. So these are psychiatric teams that make home visits, right? So it's structured with a psychiatrist, social worker, case management, nursing staff, who then go to the patient's home and make home visits. So if patients are chronically at risk, and they're chronically at very high risk, where they need repeat hospitalizations, this may be an avenue to explore, because it then becomes very logistically difficult to bring them to PACE and whatnot. Okay. So treatment for psychosis, unlike the other disorders where I think mild cases the PCP could manage, I do think that anybody with a diagnosis of schizophrenia or bipolar 1 disorder should be seen by a psychiatrist, because these are now categorized as severe mental illnesses, and most PCPs are probably out of their comfort zone when treating someone with schizophrenia. And like I mentioned earlier, if psychosis is brand new, a 70-year-old who's never had psychosis before, I would be very suspicious for some sort of medical problem going on. I would mention that the age range for developing schizophrenia and bipolar disorder in males is late teens, early 20s, early to mid 20s, and in females, 20s to early 30s. Okay, so the chances of developing schizophrenia or bipolar disorder at 60 or 70, basically, it's not zero. There's like rare cases where that might happen, but it's extremely, extremely rare. So like I mentioned earlier, usually treated with antipsychotics, Haldol, Zyprexa, Abilify. These antipsychotics are really cool in that there's many ways to take the medication. There's tablets, there are capsules, but then there are also disintegrating tablets, where the moment it touches the patient's mouth, it sticks to their cheeks or their tongue, and it dissolves into their body. And so patients who you have a suspicion of cheeking medications, this could be an option to bring up to the provider, like, hey, I think this patient has been cheeking and spitting out medications. Can we get like a disintegrating form? It's formulated so that it sticks and the patient cannot cheek it, right? If they cheek it, it will be absorbed. So, and a lot of medications come in injectable forms as well. And injectable forms, they can last up to 2 weeks or a month. So again, really good for patients who have a difficult time taking medications every single day, patients who don't want to take medications every single day. Could be a battle for the caregiver as well. So various reasons to use the injections. And if the psychosis is, if the timeline fits where they were using cocaine, they got psychotic, and you have like good data to support that, I would advocate that to the provider that, hey, this patient was using substances. They probably don't need to be on an antipsychotic long term, right? So this information is really, really helpful. And as a psychiatrist, when patients enter my office, this is the information I wish I had, but then it becomes very hard to gather from the patient, who may not be the most reliable reporter, right? And the reason for this is because, these medications have a lot of side effects, and we try to minimize as many medications as possible, especially in the older population. Okay. So I wanted to dedicate a little bit of time talking just about common medication side effects, what to look for. So SRIs, again, serotonin reuptake inhibitors. The most common side effect is stomach ache. But the stomach ache usually only lasts for the first 3 to 5 days, and usually it goes away. So my advice to patients is, if the stomach ache is tolerable, bear with it for a few days, and it will go away as your system gets used to it. Now, if the stomach ache persists or it's too much, then that's something to let the provider know, like the patient's constantly complaining, and the patient really cannot tolerate it. Some SRIs are associated with weight gain and weight loss. So patients may notice it, they might not, caregivers might notice it, so something to be cognizant of. SRIs, it's relatively safe as a medication class. However, if a patient misses a dose or they go a few days without the medication, they may experience pretty bad withdrawal symptoms. Nothing life-threatening, but they'll feel really uncomfortable. They would have a lot of stomach upset. They would have rebound anxiety, suddenly feeling more jittery. Some patients might describe brain zaps. It's funny because I cannot tell you what a brain zap feels like, but each time a patient comes into my office and I ask them brain zaps, they tell me, that's exactly it. And I'm just thinking, well, I don't actually know what that is. But based on how many people report it to me, it's like this phenomenon where it feels like some sort of electrical current in their head. Again, harmless, but something that patients might bring up. Next, benzodiazepines. So, I think this has been stated several times today already. Psychiatrists treating older adults tend to not like benzodiazepines. So things like lorazepam, diazepam, Ativan, Valium, Klonopin. It's a nasty medication to work with because it has a very high addictive potential. So their bodies and their minds will grow dependent on the medication. So once we start a patient on the medication and they require more and more of the medication, it becomes very hard to take it back. And if you take it back too quickly, they might go through seizures and then potentially life-threatening withdrawal. And the main reason why we do not like prescribing this medication is because at higher doses leads to more sedation. And these patients already, they have unsteady gait, their walking is already unstable, they have to hold on to either a cane or walker. You add all these things up and it's a recipe for falling. And number one reason for older adults being hospitalized, falls and broken bones, right? So we want to do our part in minimizing that. And overdosing on these medications may lead to respiratory depression. So, suddenly stopping their breathing. Now with antipsychotics, some of the side effects include muscle rigidity, so people might feel more stiff, commonly in their arms, can happen in their legs, their neck, or their back. So you might see people, someone who used to stand tall, they might be more stooped over, they don't pick up their feet as they're walking, they're kind of shuffling their feet, dragging their feet as they walk. They might develop tremors, so they might be sitting there and their hands just might be shaking if that's new and they recently had an antipsychotic prescribed, something to notify the provider about. Many antipsychotics are sedating as well. So, we try to be mindful of this because, again, sedating medications lead to more falls, right? So that's why we only prescribe antipsychotics when they really need it. And weight gain can be a huge issue for some patients on these medications. And finally, sedatives, sleep aids. So one thing I didn't talk about too much today is this idea of insomnia. So as people get older, they need less and less sleep, and they tend to go to bed earlier, and then they wake up earlier, right? So people will confuse this for insomnia. Oh, I need to be sleeping. But when you ask them to give you like their hours of sleep, they'll tell you, oh, I go to bed at 7 p.m. and then I wake up at 3 a.m. And then you're thinking, well, of course at 3 a.m. there's nothing to do, and you feel like you should be in bed, but in terms of your sleep drive and your time in bed, time asleep, everything is actually pretty normal, right? So we try to do a thorough job when assessing for sleep issues with older patients, because again, anything that helps them fall asleep will keep them drowsy in the morning. And drowsy in the morning, they roll out of bed to use the restroom, they're gonna fall, right? Some of the medications also lead to sleepwalking. So, yeah.
What do you do if you have someone because you talk about people with insomnia, what about people who are sleeping too much?
Yeah, so people who are sleeping too much it's one of two things usually. It's usually depression or it's dementia, right? So with depression, that's easily fixable. You bring in more activities to entertain them, you get them more active, you get them out more, you re-energize them behaviorally, and then the medications will kick in and help them with the depression as well. With the dementia part, it's a little bit trickier because imagine living in a movie and the movie you're watching through your eyes is in a foreign language, right? And you're sitting in a room where you don't really understand much. You're probably going to doze off, right? So to me, that's not a problem. So like if a demented patient is sitting there and they're dozing on and off, that's usually not a problem. And how we know it's a problem is if we give them food and they're dozing off while eating. That is oversedation, okay? And that's the key point that we look for. If these demented patients respond when they're given activities, specific things to do, that tells me it's not oversedation. They're falling asleep because they're bored and they're confused. They don't really get what's going on around them, So I guess the comparison to that would be, depression. It's like seeing the world through sunglasses, right? It's darkly tinted. Everything's boring. Everything's dull, but you still kind of get what's going on in the world. Right? Does that answer your question?
Yeah.
Right. The laptop, I guess, ran out of battery. So, but we're about done anyway. So, I don't know if anybody has any questions at this time. I know that was kind of like a whirlwind of stuff.
You have in the future or plans to fix all this stuff? What are you predicting in 5, 20 years? As much as I want to fix all of these things, I don't know if that's possible. But yeah, Studies or something?
There's been a lot of studies and I guess it's harder to call them breakthroughs. There have been some developments in research for treating early stages of dementia, so people who have just a touch of cognitive difficulties. There are some new medications on the market that may change treatment and outcomes for demented patients, but that's still very much in its infancy, and so we don't readily have that available. And it's also very, very expensive right now, unfortunately. I think with the rest of the psychiatric illnesses, I think it's a good thing that society has been more or less stigmatizing, about different mental illnesses. So patients, I think, are more aware now, and they bring these issues up. And I think, care teams are more aware as well, which is a good thing. So yeah, I think the outlook is positive. I just don't know if I single-handedly will have, in effect. Yeah. Any other questions? Okay, cool. Well, thank you so much for having me. This was a pleasure talking to you guys. And just like Dr. Barsegian, if you have any questions, feel free to reach out to me. I'm happy to help in any way I can.